Good morning and happy Teach Me Tuesday. My name is Lisa Houston and I am a clinical nurse educator specializing in NICU education. And would you believe that it is the fifth Tuesday of October? We got 5 of them this month. That's pretty exciting. So because of that, I decided to try something fun and new, talk about one of my favorite things. We all know my most favorite thing is the placenta, but I love NRP. I love the evidence-based practice of NRP. I love how NRP is kind of continually reinventing themselves. And as soon as they put a book out, they're back into strategic sessions to say, hey, what could we be doing better? So what I wanted to do is review the 4 topics we went over this month and then connect them back to NRP and kind of how NRP is helping with reducing negative outcomes, adverse outcomes, and how they are also playing into some of these things that we talked about. So let's dive in. So we covered intubation, brain injuries like IVH, infant mortality, and delayed cord clamping. All 4 of those are pretty well connected to NRP, especially when we're going to kind of connect it into when we're resuscitating within the unit, not just during a delivery. But all these areas play a critical role in the stabilization of our babies. We're going to show how they connect together, what we can do in an emergency to help with these things, what a delivery could look like with well-timed interventions, which is what the NRP algorithm is all about, and kind of how we can use that together to improve our outcomes. So circling back to intubation, which was week 1 of October, and we know that intubation is indicated in many different circumstances. We are getting to a place in the NICU where intubation is not our first line anymore, right? When I started 20 years ago, almost 21 years ago, I've been a NICU nurse. I would never imagine. I'm gonna go on a limb. I'm gonna say 28 weeks and under not being intubated, especially in the first few days of life, but definitely a 25 week or and under. And in the last couple years of my career, my bedside career, I have seen 23, 24 weekers starting on CPAP, NIMV. It is wild. It's no longer immediate. But now NRP tells us that intubation is indicated if PPV is inadequate or prolonged, or if chest compressions are needed. So remember, if it is time for chest compressions and you have not gotten into intubation, which is the A of Mr. SOPA, artificial airway, we need to get that in to try to decrease some of those long-term outcomes. IVH can be directly linked to periods of hypoxia and hypoxemia, having to need to do chest compressions, having rapid changes in your circulating blood volume. So we want to prevent that by watching the baby, working through the algorithm, and getting in there sooner. We want to perform intubation without delay in situations with hypoxia, fluctuating oxygen requirements. Even in the NICU, right? We walk this super tethered line of when is the best time to intervene with intubation? Have we given the baby time to try this on their own? Have we maximized our settings and gotten our OG and make sure our CO and our Fisher-Paykel is good? And if we're getting to this climbing oxygen with higher risks of hypoxia, it's probably going to be time to intubate. So just something to think about. So I'm going to have 3 top tips from each of these things, kind of connecting it together. So number 1, we talked about positioning and ventilation before intubation. So I'm going to get them into that sniffing position, giving them effective PPV. Make sure you have multiple masks at the bedside because the mask needs to seal onto them. Sometimes when the masks get warm, they kind of like morph. You might use the same mask size and just a different one. Pre-medicate whenever you can. We talked about the medications used during intubation as available. In a delivery, we're not going to have them, right? So if we're doing kind of those initial NRP steps during a delivery, we're not going to have atropine and fentanyl for that. But if we're in the NICU, maybe we're doing a controlled intubation, maybe we have decided to give surfactant. We're not doing any of those Ensure or LISA or SALSA trials yet. So we're going to go ahead and intubate for the surfactant. Use pre-meds whenever you can. And then we want to confirm our placement quickly. We had the CO2 detector on the previous slide, but using the CO2 detector is the number one way, other than X-ray, to really guarantee that it's in there. Yes, you want equal breath sounds. Rising heart rate is your number one sign that your PPV is effective, but your heart rate may not come up with a tube still well placed. So those are things just to keep in mind. Get that CO2 detector out and make sure it's going well. So that's our connection between our first week of October and NRP. Week 2, we talked about IVH. So how can we connect IVH back to NRP? So as a reminder, IVH is graded from 1 to 4. Higher grades are more severe forms of hemorrhaging. When we are practicing NRP, we are reducing the risk factors during resuscitation, including hypothermia. Unstable temperature in the delivery room or during a resuscitation increases your infant's risk for having severe outcomes such as severe IVH. So NRP, first thing they tell you, what's on your equipment check? Is your bed warm? Do you have a thermal warming mattress? Do you have a plastic wrap for the baby? Do you have a poncho? Whatever it is. Then they also talk about gentle ventilation, how we're starting everyone on 20/5, PIP of 20, PEEP of 5, so that we're not just blasting their lungs. If we need to do chest compressions, making sure we're doing it in a gentle fashion in as short amount of time as possible. So this gentle ventilation, the close monitoring of the oxygen to prevent the rapid flow and change in the blood flow to the brain is going to be so key for reducing our risk of IVH. So our top 3 tips, we're going to do this for each one. During resuscitation and stabilization, limit excessive handling, moving the baby to avoid those abrupt pressure changes. Remember the baby is just really fragile. Those blood vessels that are going to the brain are really fragile. We try to turn them in the bed. Remember there's a lazy Susan on some beds, so you can turn the bed instead of the baby. Tip 2 is keep the head in midline, keep it in a neutral position to help maintain stable cerebral perfusion, avoid excessive venous pressure. And then our top 3 tip is just control your ventilation and oxygenation during resuscitation. Whether that's going to be in your NICU in those first few days of life, maybe your patient came down on CPAP or NIV or NIV-NAVA, something like that, and it's time to intubate. We still want to have really good ventilation, stable oxygen, closely watching them during this resuscitation, closely watching them if we're getting to a place where we need to intubate or we're getting to a near code in the unit. We want to avoid those rapid changes in oxygenation and reduce the fluctuation in the blood flow to the brain. Week 3, as an honor to October being Infant Loss Awareness and Miscarriage Awareness Month, and October 15 being Infant Loss Awareness Day, we talked about infant mortality. And NRP really stresses a lot about infant mortality in what resuscitation looks like, when resuscitation should end, when resuscitation should not begin. Really, for babies under 25 weeks, it is still a parent's decision how much resuscitation they do want performed. I will say the 22 and the 23 weekers are where we're still having more conversations and we're talking about, hey, what is this resuscitation going to look like? Do you want intubation? Do you want chest compressions? From there, it's how long are we doing it? Maybe this is a term baby. Maybe we are trying to make sure we have good, quick interventions to prevent outcomes such as HIE. HIE is a big part of infant mortality and long-term morbidities. So we want to make sure that we are doing quick, effective resuscitation, even in our term babies, especially in the setting of something going on with mom, such as a placental abruption, uterine rupture, etc. NRP also teaches us how to identify when resuscitation efforts are futile. In the most recent edition of NRP, they say that we can do chest compressions in a full resuscitation for up to 20 minutes, giving multiple doses of epinephrine every 3 to 5 minutes, continuing your coordinated compressions and ventilation. But there might be a time where it's time to stop, and that does kind of key into this infant mortality. Additionally, there are babies with life-limiting diagnoses that we may not be resuscitating, so that's an important part as well. From there, we would talk about our top 3 tips. So swift intervention with PPV and administering PPV within the first 30 seconds of birth. I will also say that if you're having a severe apnea and bradycardia on the unit in your baby's bedside, getting your PPV started after stimming is a very, very important step. Timely interventions are going to avoid those long-term complications like HIE. They also will avoid long-term complications such as PVL, which we talked about during week 2 when we talked about IVH versus PVL versus hydrocephalus. PVL mostly forms, it can form during an IVH situation, but also from periods of hypoxia. And so just these kind of cysts are forming. So we want to really prevent that from happening. And then HIE is a primarily right now being studied as a birth trauma, a birth diagnosis. We're learning more and more as we see MRIs of babies that were in the NICU that end up having brain scans that are similar to HIE. So lots of, what's the word I want? Emerging literature coming out about that. You can tell I've been sick because I'm like spacing my brain out here. Tip 2, we want to really watch our heart rate. Remember, if your heart rate is less than 60 after you've been doing 30 seconds of effective PPV, remember we prefer that PPV to be through an ET tube before we get to the place of chest compressions. If you do not have someone available to intubate, of course, chest compressions would start before with a good seal on your mask and getting effective PPV. But heart rate less than 60 after 30 seconds of effective PPV, because most infants are going to recover from a low heart rate from PPV and will not need chest compressions. And then tip 3 is we want to just recognize when resuscitation is not indicated, such as, if the baby is a stillbirth, the baby has a life-limiting diagnosis, and we've had a conversation with the parents. If the baby has had a prolonged resuscitation, we've exceeded 20 minutes and it's time to stop. But in situations like trisomy 13 or 18 or anencephaly, there are a few other diagnoses where we are not going to resuscitate the baby. We may do comfort measures, have the baby held. All of these things are going to play together. NRP has a chapter on ethics, so it's a great connection in here. It kind of gives you some good guidelines. And remember that the parents can change their mind. I think that I've been in situations where they've changed their mind at the delivery, and so that's really important to honor what they need in that moment. Week 4, we talked about delayed cord clamping. So delayed cord clamping is a huge part of NRP. NRP was a huge proponent of pushing this forward. We talked about this extensively last week, but delayed cord clamping is just this waiting 30 to 60 seconds after the baby is born to clamp the cord. Lots of emerging literature about using a warming table or something close to mom so that the cord can remain intact and resuscitation could begin. Remember, we are doing delayed cord clamping for vigorous babies, and a big part of this is to reduce the risk of IVH by increasing the baby's circulating blood volume. It also improves iron stores, reduces the need for blood transfusions. So all of these are great reasons, and it's a big part of those first 30 to 60 seconds in the NRP algorithm. NRP, the timer starts when the baby's born, not when the baby's placed on the table. So those first 30 seconds when you're doing your rapid evaluation, is the baby vigorous, is probably happening during delayed cord clamping, which circles back to the mass importance of working with our OB labor and birth team. So tip 1, NRP recommends delayed cord clamping to improve blood volume for vigorous babies for at least 30 to 60 seconds. Definition of vigorous is, are they crying? What is their tone? And are they breathing? If they're crying, they're breathing, and their heart rate's going to be greater than 60 if they're crying. So I always say crying in good tone, you're probably got a vigorous baby. Tip 2 is that effective communication between the NICU and OB team. We can have our resuscitation equipment ready to go, be ready to initiate those efforts. And then we want a plan for thermal regulation. DCC is most effective when the baby remains warm. So does that mean that we put a sterile poncho onto the OB's field? Does that mean that we start investigating the use of these other tables? If you're seeing this and you're still interested in those articles, send me a message and I'll get you some articles about the table use during resuscitation. But there are ways to do this and to keep the baby safe and have positive outcomes for them during resuscitation. So we can tell our parents all of these great things, right? NRP is about their best start. It is also the program that we use as bedside nurses for babies in the NICU to evaluate what they need if they're having apnea and bradycardia. This is for us to use to have life-saving care. And they are well evidence-based guidelines to tell us what to do so that we can prevent things like IVH, which can lead to hydrocephalus, and to prevent further injury by controlling oxygen and blood flow and prevent injuries such as HIE. Delayed cord clamping is safe and beneficial, increases that blood volume. Parents may ask you about NRP, or what are the steps you would take to gather your team if the baby is having apnea and bradycardia. Maybe you're resuscitating a micropreemie, so the parents already kind of know what we're going to be doing. Someone's already talked to them about delayed cord clamping. Someone's talked to them about, hey, your baby is a micropreemie. We're going to watch what they do. These are the things. Do you want to have us intubate? Do you want us to do chest compressions? That would be the next step. So that idea of what the NRP algorithm is may already have been discussed with them. From the onset at birth, I don't think parents have as many questions about NRP, but as the baby stays in the NICU, they may ask you more questions such as, what would you do if the alarms went off? How do you gather your team? How do you help a baby through an apneic or bradycardic episode? What is the certification for the nurses here, whatever it might be? So just knowing kind of more of, that NRP is an evidence-based guideline. It is continuously updated. They have a spirit of continuous improvement, making sure that they have the best evidence out there and that we get recertified every 2 years, all those lovely things that we do. But really, we do this in a systematic way to prevent ongoing brain injury, whether that's in the first few days of life or the entire time that the baby is there. So we've connected all these critical neonatal care topics from the month of October back to NRP, one of my favorite subjects. I'm very passionate about NRP and how important it is. I also think if you do not have an apnea or bradycardia algorithm for your unit, you can create one using the NRP guidelines as kind of your factual basis of what we should be doing with the steps and when is vigorous stimulation required. What does moderate stimulation mean? If you're giving the baby PPV, are they getting moderate stimulation? The answer should be yes. Or if you're moving them, suctioning them, etc. All of those things will help you with long-term adverse outcomes such as PVL, which is something that should be tracked on your unit, and you should be looking for ways to reduce it. Delayed cord clamping is just going to be a step of NRP that you need to be able to communicate, is the baby vigorous, with your OB team and having protocols for your neonatal stability. So NRP education equips us to provide the highest standard of care, giving babies the best chance for healthy development. So thank you for joining me for this 5th Tuesday in the month of October. I'm hoping to have more connections between our Teach Me Tuesdays and NRP as we move along, so this might not be the last time you see a recap connection. I hope you learned something. Feel free to message me or leave a comment if you have any questions, and I will see you next Tuesday.